For me, it's very important that the patient understand what and why I'm doing this. What is the medication? What is it going to be doing for them? What are things to look out for as far as side effects, adverse reactions, kind of red flags kind of thing? Because from my experience, and I guess this is personally and kind of from my mother, being a nurse and being around that a lot, if the patient doesn't understand what and why they're doing it or what's wrong with them, they're significantly less likely to be aware of what they may or may not be doing good or bad that's making it better or worse. They're going to be less inclined to try and better themselves, whether that is exercise or diet or better sleep habits, sleep hygiene.
All right, well, welcome everybody. Today we're continuing our series about learning about the different providers at Kirkpatrick Family Care. And we've got Nick Austin here today. Nick, how's it going, man?
It's going very well. How are you doing
I'm
today?
doing all right, man. It's
Wonderful.
Friday.
Indeed.
It's Friday.
TGIF.
TGIF. Well, I think, Nick, I want to hear more about you and your background, your story, because I think it's so important for the relationships that we have with our patients are a two-way street. And we spend our time in clinic learning about our patients, but I think patients want to know more about their providers. Yeah. And so I'd love for you to tell me kind of about your background and where you're from, where you did your training, and lead us up to how you got to Kirkpatrick Family Care.
Okay. Well, I'm from West North Carolina. Okay. I grew up about 30 miles south of Asheville, which has been on the news a lot last year or so. Lived pretty much my whole life in North Carolina. Did undergrad and some grad school to Appalachian State.
Oh, right.
Then went to PA school at Lenoir-Rhyne University in Hickory, North Carolina.
Okay.
A lot of my early medical exposure was from my mother. She was an ICU nurse for about 30, 40 years.
Dang.
And I was luckily fortunate, to do a medical internship when I was in grad school in South Africa.
Whoa.
I got quite a bit of my clinical hours volunteering at a free Christian health clinic in Roatan, Honduras.
Wow.
On the Bay Islands. Then my rotations were kind of all over the country, and I was even able to coordinate my last rotation, which was my elective, and I was able to go back to Africa. And I did 6-7 weeks in Levi Mwanawanawath in Lusaka, Zambia, which is the capital, and spent a lot of time in the trauma ward.
Wow.
Which is kind of like the ED, and some GI and general surgery. And we were just talking a little earlier, I did my OBGYN in Utah. And then about 2 months before I graduated, and already start putting my resume out and stuff and looking for a job and Indeed and all, the websites. Actually, I don't know if I can say those kinds of things, but a recruiter actually reached out to me.
Okay.
Because I was looking for internal medicine, outpatient, close to a city, but not a city. Ideally private practice. So that kind of more family-centered.
Yes.
Employees, or it's a big family kind of thing, as opposed to corporation hospital kind of system. And wanted to be near outdoors. Grew up being in the woods pretty much my whole life, and it kind of fit the bill. So actually, when I was in Utah doing my OBGYN, your dad brought me out here for a weekend and interviewed, and spent the summer back in North Carolina, and drove out here and moved here in August of 2019. Actually.
Wow. So been here 6 years this summer.
Almost, yeah.
Wow, that's amazing. Well, before we start getting into, Longview and hearing about, just your time here, I was thinking I was going to be asking you about North Carolina. I didn't even know South Africa was on. So please tell me, what was spending time in South Africa and medicine in South Africa like? That must have been an incredible experience.
Well, when I did, excuse me, when I was in South Africa, it was medical internship.
Okay.
And there was a lot of red tape, so we weren't able to do, and this was when I was in grad school, cell molecular biology. So we couldn't do pretty much any hands-on stuff legally.
Okay.
So it was a tremendous amount of shadowing, but we got to do a lot of a lot of different types of medicine, anything from going to podiatry clinics and hospitals in trying to think, it's a long time ago. This is almost 15 years ago.
Wow.
And see, diabetic ulcers that are an inch deep, and they've had them for 20 years, and they're never going to heal.
No. Oh, my
or
goodness.
I saw A1Cs in the 20s,
Wow.
which you never see here.
Yeah.
A lot of rural clinics, some homeopathic, because the medicine there is a little different.
Okay.
So there's even a program at University of Johannesburg for homeopathic medicine,
Interesting.
which a lot of mainstream allopathic medicine doesn't consider to be
Okay. Yeah.
data based.
Sure.
We'll say it as that, and but it was pretty incredible. Then when I was in Zambia for my medical rotation, that was quite the experience because I was there doing my medical rotation. So we got to see. I could show at some point. I need to show you a bunch of pictures.
Yeah, please.
When I was doing my surgical rotation for about a week and a half, one woman, she thought she was pregnant for many, many, many months, longer than she should have been.
Oh no!
And she came in, and I didn't have any of the build up to it, but I was there assisting in surgery.
Yeah.
She had an ovarian cyst the size of a standard old school watermelon.
Oh my gosh!
It was probably about this big. Anything from that, I remember fondly or not, one gentleman who was a very uncontrolled diabetic, older male gentleman, really bad neuropathy in his lower extremities, gangrene, and we were cutting half of his foot off essentially.
Man.
And the surgical ward was very interesting because it was very rudimentary.
Yeah.
Because they do the best they can.
Yeah.
And I remember they did epidural and pretty much numbed him from, I think it was the waist down, and then just put a sheet at his waist. So they were doing surgery on one end, but he was totally awake and coherent the entire time on the other side of the sheet, but he couldn't feel anything.
Yeah.
And he was cracking jokes and hitting on the nurses.
Oh my gosh.
While we were
just a different world.
Sawing half of his foot off. It was incredible. I saw just about everything you could think of.
Yeah, I would imagine that spending time, which I've never done anything like that and had that experience. I would imagine that would change your perspective about not only just life, but just medicine, comparing what is in Africa compared to back in the States. Did that change your perspective or change you, how you think about healthcare or medicine in general, just seeing kind of what other places of the world have that they don't have that we have, kind of a thing?
Everywhere I've been in the world has always changes my perspective. I mean, in this case, yes, absolutely medicine. But whenever I do travel, especially in a lot of third world countries, developing countries, it kind of refreshes my sense of humanity.
Yeah.
Because most of these places, like Guatemala or Honduras or Nicaragua or Nepal, incredibly poor, but they're way happier than most people I know are.
That's so interesting.
They still live with extended families in their big houses, and they take care of each other, and they're just happy with having nothing.
You think that's because they have a sense of community amongst themselves? It's like a real strong community, or what is that even despite having nothing, they have everything? I don't think
they're used to, they don't know what it's like to have much. And they still just have to rely on each other and anything that they can do to better themselves and take care of their family, kind of thing.
Dang, that's amazing. Well, thank you for indulging me. I was like, I was not expecting we would talk about that, but I was like, that's amazing. I had no idea.
I could talk about it all day.
Yeah. So then tell me, you it sounds like one of the reasons you came to the Northwest and came to Longview in particular is there were some aspects maybe of, although the South and North Carolina is very different than Washington, there were some things that you liked about North Carolina that whether it's the outdoors or whatever, that Washington had similar things. Can you talk about maybe the things that you thought you might like the Northwest for, and then how living in the Northwest has lived up to your expectations in terms of those things that drew you here in the first place?
Don't get out as much as I would like to anymore.
I bet.
Got a little girl now.
Yes. Yeah. Pearl.
But A snowboard, really very much enjoy that. Snow's a little different out here, and it's not my biggest, I don't want to say issue, or maybe my frustration with out here is where I grew up, everything was at your fingertips. So I could be in 4 state parks or 5 national parks and a 15-minute drive. So everything here, it's bigger and it's grander, but it takes longer to get there. So it kind of takes a whole day.
Yeah.
So you really got to plan it a little bit more.
Okay.
And then also, I'm just not familiar with the landscape, the geography.
Yeah.
And when I moved here, I mean, it was 8-9 months. The pandemic started, and everything shut down.
I didn't think about that. Oh my gosh.
So I wasn't able to get out and meet a lot of people, or even like state national parks were closed.
Yeah. Oh man. Wow. That's crazy. I totally forgot. You said came out here in 2019. Yeah. Like that was. I can't believe I forgot about that. That was the time. Well, crazy man. Well, snowboarding clearly is something we were just talking off air about how you. I'm going to butcher the terminology because I'm so bad at this. You're like double, triple, black diamond all over the place, so incredible that you are, it sounds like been all over the place, North Carolina, Washington, anywhere in between, and snowboarding. That's pretty cool. So I think people oftentimes think that we're like sort of these people that just live in a medical office and go home. Yeah, right. But like, that's so cool. You can be a snowboarder and be really incredible at it, double black, like I said, I'm going to butcher the terminology, and then take care of patients. And, it's like, that's just you, that's just life. And I think that's so cool to see that. I never would have guessed that in our, clinic, we had someone that would go down like the scariest, craziest, paths possible. So that's really cool, man. It just, I think highlights the thing that we're more than just, these people that wear the white coats,
Yeah.
That's cool. Well, one of the things that I was, we're thinking, we want to get to know you because doctor-patient relationship is super important. Mm-hmm. And I'm just curious if you could maybe share your thoughts on kind of keys or important aspects to developing that doctor-patient relationship so that we can take better care of our patients.
For me, and I will have to give my mother a lot of credit for this, it's very much about addressing each patient, because everybody's a little different.
Yeah.
Just personality. I mean, obviously medical problems and things and whatnot. But everyone's individual. Everyone's individual. So I like to think that I try and go in and address things in an individualized manner. In the sense of where this person came from, what they've been through, why are they here? Is this a behavioral health? Is this a physical health kind of an issue? And what they're trying to get out of coming in to see me on that day and that particular time. So I think it's very important to approach each and every patient when you go in with a sense of maybe not first and foremost, but respect, empathy, be a good listener. I think that's a very important part of our job that I think is also, and kind of going back to, my time in Africa and stuff.
Yeah.
They practice medicine exactly how we do, which I found was very fascinating as far as like the organization of like a soap note and how they approach a pragmatic or a diagnostic perspective and, symptoms, and they bring it all together and kind of create a plan in their head and whatnot. But there they ask a lot more questions. They talk to the patients a lot more. They do a much more thorough physical exam because they can't afford CT scans and MRIs and things. So a lot of the time I would find it just incredibly fascinating that they would treat based off what they're pretty sure it is, and then they would do whatever diagnostic test as minimal as they could to confirm that.
Interesting.
Which I was incredibly impressed about.
Yeah. Oh my gosh.
So when I'm going into a room, just trying to, as I said, be a good listener and trying not to repeat myself, relate to the patient.
Yeah, I mean, it sounds like I think that's really cool to hear, because I think there's this perception that oftentimes is well deserved by us in the medical field, that there's like this transactional thing. Hey, I come in as fast as possible. I'm trying to, maybe not even help you, but just do something and then get you out of there. But it sounds like when you go into the room, it's like, I need to listen. I need to hear this person out. I need to learn about them, not only them as a person, but like, how can I help you today? What is the thing that you came? I like how you said that. What did they come to me for? And it's a very intentional listening to them, learning about them as a person, and it's not trying to get in and out as fast as possible. It's, hey, we're here to help you. And I think there's a lot of people that think of medicine and think of the exact opposite of that. So that's really cool to hear that within your sort of framework for how you approach patient care, it's very patient-centered and sort of, a holistic kind of approach, because you're putting the patient first.
That's the word I was thinking of. It was holistic. Today, I saw a patient for insomnia, and I could just be like, okay, here's a pill. It's going to help you sleep better. Yeah. But is it stress? Is it a
substance abuse,
or stimulant problem? Yes. Is it sleep apnea?
Yes.
Is it a number of things?
Yeah.
As easy as it is to say, hey, here's a pill. This will help you sleep better.
Yeah.
I want to fix the problem. I want to figure out what's causing the issue, because more times than not, it's whatever the source of it is causing a lot of other problems as well.
100%. And I love that, because basically you're describing, I want to get at the root cause. I want to get at the root cause of why you're having whatever problem you're having. And I mean, you probably hear this too. I feel like people are often like, why did someone just throw this medication at me? Why didn't they get to what's actually going on? And maybe that is still treated with a pill, but if we don't know and we're just putting a Band-Aid on it, how is that really helping anybody? And it sounds like one of your core tenets is, let's take time to learn about the patient, to listen, to actually figure out what the root cause is.
In addition to that, even if it is, well, yes, here's a medication that I think is going to help in the end.
Yeah.
For me, it's very important that the patient understand what and why I'm doing this. What is the medication? What is it going to be doing for them? What are things to look out for as far as side effects, adverse reactions, kind of red flags kind of thing? Because from my experience, and I guess this is personally and kind of from my mother, being a nurse and being around that a lot, if the patient doesn't understand what and why they're doing it or what's wrong with them, they're significantly less likely to be aware of what they may or may not be doing good or bad that's making it better or worse. They're going to be less inclined to try and better themselves, whether that is exercise or diet or better sleep habits, sleep hygiene. And I find that even before you started, and I did a lot more cardiology and reviewing echocardiograms. And, I draw pictures. Okay, this is the way of blood flow. This is what's the issue with the valve. Okay, well, this is how we get a systolic and diastolic blood pressure.
Yes.
I've had many patients say, no one has ever sat down and explained something to me like you did.
Wow.
And I'm 73 years old.
Yeah.
I understand what's wrong with my heart. I understand a lot of the things that I didn't know that were bad that I'm doing, but now I do, and I know why they're bad, and I'm going to try and not do them as much anymore.
Man, that is so good, because I think you just said two things that I would say most people in the world feel like doctors and primary care providers and physician's assistants and nurse practitioners are not good at, which is listening, which is the first thing you said you really think is important, and educating, right? The educated patient is going to do better than the person who's feels like they're in the dark.
10 out of 10.
10 out of 10. Yeah. And so that's so cool that you are passionate about educating patients. And clearly, the patients love that.
Yeah, they do. I also have to give a lot of credit to my academic mentor, for better part of 10 years.
Wow.
He was the reason I went to Africa twice.
Wow.
He was born and raised in Zambia.
Wow.
That's where he's from.
Dang. Yeah. That's so cool, man. That's awesome. Well, one of the things that I think is incredible about primary care is that other than the emergency department, you are the first sort of touch point for someone with any medical problem. Any person that has a medical problem, whether that's internally, externally, musculoskeletal, an organ, a mental health issue, a substance problem, a lifestyle, whatever, they're coming to you. And literally your duties, clinical duties, encompass literally every aspect of medicine. And so I'm curious to hear, what is it about primary care? You can do anything, but what are the things about primary care that you love the most?
Part of that is a weighted question.
Okay.
My background is predominantly science. Mm-hmm. So I really like being able to see and learn new things every day, because we're all learning everything new. And patients think, and they come in, and I often get the impression that the patient thinks that I know everything.
Yeah.
And I often, and I was actually kind of taught to never tell a patient you don't know. Mm. But I have actually oftentimes found the opposite and say, I really don't know the answer to this, but I'm going to find out.
Yeah.
And I'm going to let you know. We're going to have you come in and follow up.
Yeah.
And I think that is a big part of the trust. Mm-hmm. That bond between patient and provider, that if you're willing to say, you know what, I'm not real sure, but I'm going to figure it out because I care about you.
Yes.
So beside that, kind of what you already said is every patient, every appointment is a little bit different.
Yeah.
I could see a urinary tract infection now. I could see a possible stroke next. I could see, arthritis of the right knee, or a torn ligament somewhere. Every day is completely different. So it keeps you on your toes.
Yeah, that's so cool. I love, definitely every day. I can imagine how different every day must be. But I love what you said about not being afraid to say, I don't know. I think people want to trust you. And when we, put up a facade like we're more than we're not, that helps nobody. And patients can tell that we're not being authentic. And I think that's so powerful. Like, hey man, I don't know what's going on, but I'm here with you and I'm going to help you figure it out. And we're going to help you get better. I don't know what that is today. I want to be honest with you, but I'm here to help you and we're going to get it done.
Yep. This is how we're going to start.
Yeah. That's good, man. That's so good. Because I do think there is a lack of trust within healthcare. And part of that is, I think sometimes, we're just not honest. And I don't mean, I promise I'm honest, as I really believe I am. We as an entity of healthcare, doctors often aren't as honest as we should be. And I think people will respect you. I'm sure no one has ever said like, oh, he said he didn't know, but he was going to help me. What the heck? No, they're like incredibly grateful that you were honest and there with them.
Yeah.
That's cool. All right. The last thing I wanted to touch base on really quickly was, in primary care, it's really incredible. I think the things that patients will tell us that maybe they've not told anybody else in their life, that are really sensitive, or the things that we're asking patients that might be, kind of, important questions, but can be difficult to ask. So I'm just kind of curious. I really think being able to have difficult conversations around touchy subjects, whether that's substance abuse or mental health or weight change or really anything that might have an emotional component, can be challenging. And I'm just curious, how would you tell patients, when they're thinking about, man, I wonder if Nick should be my primary care provider? How do you deal with the challenging problems, the vulnerable, questions that can be sensitive?
I think a big part of that is one of the first questions we talked about, as far as coming in, and being with the patient, relating with the patient, getting on their level wherever that is, whether they don't have more than a third grade education, or they're illiterate, or an understanding where they're coming from. Mm-hmm. I try my best to relate with the patient with whatever I have been able to experience personally or objectively in my life, whether that's from travels or family or hardships or overcoming boundaries or whatever it may be. Because I think a lot of the times, and that's a big part of depression, and that's a big part of suicide, is just, I'm alone. And nobody understands what I'm going through. There's nobody here, or there's nobody around that can relate to me, and I'm in this by myself. So sometimes I may actually share a little bit, maybe too much personal information with patients, but I'm just an open person, and I'd like to think that I'm an empathetic person, and I want them to be better. So I think if you can in any way relate with the patient and what they're going through, one, they're going to be more open. They're going to be more trusting of you. They're going to be more willing to listen to whatever your advice may be, whether that is a medication or counseling or seeing a psychiatrist or psychology. And it boils back down to that trust issue.
Yeah.
Because if the patient doesn't think that you actually care about them and you're trying to do your best by them, their likelihood of success and overcoming whatever it may be, whether it's mental, spiritual, which obviously we don't deal that much with, or physical, is much lower.
Yeah.
I kind of little not proud by any means, and maybe even a little embarrassed by this, but coming from North Carolina, I come from a place of smoking cigarettes. Most of my family does or did smoke cigarettes.
Yeah.
I smoked cigarettes for about a year when I was in college, just because it was the culture that I grew up in.
Yeah.
So when I have patients come in and talk to me about quitting smoking, I'm like, hey, I know what it's like. I know how hard it is.
Yeah.
Because it is.
Yeah.
Extremely.
Yeah.
And, you can't just tell somebody you have to quit smoking. I mean, yes, obviously can, but
it's not going to work.
It's not going to work.
Yeah.
So like anything, I try and come at multi-level approach is, okay, well, these are the issues. These are the habits. There's different avenues. We can try different types of medications that go through different types of ways of as far as helping them succeed. Or there's really good books out there. But I'm getting a little off topic.
No, this is perfect.
But relating with the patient, allowing them the time to express whatever is going on so they don't feel rushed or pressured, because once again, they're going to start omitting information. They're going to be more reserved. They're going to be more resilient to really kind of say, this is what's going on, whatever it is. And I'm kind of, in my mind right now, I'm thinking a little bit more about the behavioral health, the mental health aspect, which, as unfortunate as it is, because there's such a shortage of that, mental health, behavioral health professionals, particularly in this area.
No doubt.
We have to. We don't have a choice.
Yeah.
And in the end, whether it is mind, body, or spirit, that's what primary care is.
Yeah.
We're here to address whatever the issue is. And no matter how specific or general it may be. And I'd say in science and medicine are finding out more and more that they are as interconnected as they can be. And if one is out of balance, then another one is likely to follow suit.
I totally agree with that. And I think, what you said, I think is actually going to change my practice, because I think I oftentimes, when I personally am having to address those things, whether it may be sensitive and whatever, smoking cessation, mental health, whatever, lifestyle changes that you don't want to say something that's going to offend someone, or that might they might feel uncomfortable when you say these things. And so I often would think about, well, what's the best way to say this? And of course, there's tactical ways to go about it. It's important, but like what you just described, I think was so beautiful. You're like, if you just get to know them, and it becomes obvious over time that you care about them, and that you've got this incredible trust, and that even more, that you're willing to be vulnerable with them. Like you said, you would share things of your own past with them to help relate. Then not only is that conversation so much easier to have, but they're way less likely to feel uncomfortable because they know that you have their best interest at heart, and that all you're doing is trying to help. And so I think that I'm going to take from that is just like, if you just establish trust and good relationships and be vulnerable with patients, those difficult conversations are so much easier to have for both you and the patient.
Yeah, and the difficult conversation and developing that relationship allows for the patient, in my mind, ideally to leave the room knowing that I'm not in this alone.
That is, I love that. I think that should be a theme, honestly, of us is you're not alone. We are here for you. And I love that you said that. I'm going to steal that. I'm going to steal that from you. That's incredible.
By all means.
You're not in this alone. That's so good. Well, Nick, I just want to thank you. First of all, I think we need primary care providers more than almost anything, where it's such a shortage right now. And we're so lucky that you're here and that every day you come to work to make not only people healthier in Longview and in Cowlitz County, but to make their lives better. And we need to, duplicate you and clone you because, we need so many more people for this area. We're really lucky to have you. And I mean that. I'm really thankful that you're here. And I also want to thank you too, because it's not just that you're here and going to work and helping our patients get healthier and live better lives, which is obviously incredible, but you live here. You came all the way from North Carolina. You are living in Longview. You've been here for almost 6 years. And I've seen you and your daughter out at concerts at the lake and at Extreme Machines. I saw you guys at, I just think that's so cool when we have medical providers who are not only, working with patients, but they're out living their lives amongst their patients too. So Longview would be a better place if we had more, people who put roots down here like you. And I'm really thankful that you're here and doing that. So thanks so much, man.
It's my pleasure. Community is extreme. About to put two words together, extremely important.
Yeah. Right on. Thanks, Nick.
Anytime. Thank you.